knowing when to place an implant after the tooth extraction is an essential part of the treatment planning. An early Brandenmark protocol suggested a waiting period of 6 to 8 months before an implant should be placed. And actually, some surgeons still follow this delayed protocol for all of their cases. We know now that the majority of the treatment plans don't need to wait that long, and that we may have a chance to preserve the original tissue architecture if we can intervene earlier. Confusion still exists as when the optimum time to place an implant after an extraction. And this presentation hopefully will help to clarify some of this confusion. The concept of prosthetic-driven implant placement has become a dominant trend in a treatment planning due to increase in single tooth replacement and younger age group. And only recently we have started to appreciate the important role of soft tissue on aesthetic and long-term stability of implant placement. I would like you to be familiar with this part of the image here. This demonstrates the spatial relationship of the implant and its surrounding hard and soft tissue. You will see similar configuration time and again during my presentation, as it represents optimal implant position for predictable outcome. Somebody is typing, so I ask everybody to mute the microphone. Today, I will walk you through the rationales and techniques of implant placements at various times in various points in time after tooth extraction. But let's first review some of the guidelines of implant placement. We use different parameters to evaluate the aesthetic result of a treatment, such as white aesthetic score for an implant crown and pink aesthetic score for soft tissue appearance. Basically, these are grading to evaluate the harmony and symmetry between the treatment outcome and its adjacent structures. This case was done with a subset of immediate placement called the socket shield technique with more than 8 years result. We try to preserve or reproduce the original rich profile because without the proper rich profile, soft and soft tissue architecture, an implant crown will not be able to mimic faithfully the natural tooth. And in addition, in order to maintain the long-term aesthetic objectives and result, we need very stable and hard and soft tissue dimension. We're so proud of our work. The placement looks perfect and the bones seem to be stable after many years, right? But our patient really could not care less about the design of the implants and how we place them. But they expect natural looking results. There is an implant crown in the second premolar here to replace a fractured root with the buccal plate completely gone. Socket preservation and delayed implant placement was done with 5 years post-op radiograph. The result is ideal in both function and aesthetic. This definition of prosthetic rehabilitations rehabilitation is manufacture of restorations to substitute loss of tissue. In our profession, it means tooth, bone, soft tissue. But this definition is not adequate because it doesn't mention the faithful replication of the original natural organs. So a guideline should be added to the previous definition for the surgeon, the restorative clinician, and the lab technicians to plan the treatment with the final aesthetic result in mind. In order to avoid poor results such as these. It's extremely hard to restore this kind of placement. So in order to understand the biology of the extraction sockets and the condition of the hard and soft tissues at the implant site is essential for the clinician to decide when and where future implants should be placed. Let's start with the biology of the extraction socket. Needless to say that an atraumatic extraction is essential in minimizing the damage of hard and soft tissues. Atraumatic extraction helps in wound healing and visibility of the surgical field. There are 5 stages of natural wound healing after the tooth is removed, but we are not going to elaborate on this. It is important to remember that complete soft tissue healing is between 3 to 6 weeks, and complete natural bone formation occurs after 4 months. I would like to divide the extraction socket into 4 different zones, each of which has its own characteristic. The buccal zone, the interproximal or the papillary zone, the palatal zone, and the apical zone. The buccal zone is the most important zone in dental implant. A very high incidence of peri-implantitis appears to have the implant violating the biological tolerance of this zone. Any change in this zone is usually noticeable to the eye. Nicholas Elian in 2007 proposed a simple classification of the extraction socket to describe the condition of the buccal zone. Type 1 is where the buccal bone and soft tissue are intact. In type 2, there is a partial loss of the buccal bone, and in type 3, there is extensive loss of both hard and soft tissue. Immediate implant or socket preservation can be made, but more difficult when more bone is lost. In both type 2 and 3, usually a flap is required for correction. We know that bone loss is a natural phenomenon of a edentulous ridge. An important percentage of bone shrinkage appears after the tooth is removed. We lose 40% of the ridge during the first 6 months alone, and about 50% first year, up to 5 to 7 years, as 5 to 7 millimeters. There is also vertical height reduction of more than 1 millimeter. There is greater bone resorption at the buccal aspect than at the lingual or palatal counterpart. Regarding the buccal bone thickness, studies have shown that 87% of the population have less than 0.8 millimeter of buccal bone thickness. And about 50% of the population have less than 0.5 millimeter of buccal bone thickness. 0.5 millimeter is basically the thickness of the bundle bone, the soft bone that houses the fibers from the periodontal ligament. The bundle bone resorbs rapidly after the extraction. New evidence has suggested that the net bone loss might relate to the existing backbone bone thickness. So thicker the bone biotype, less bone loss after extraction. We also know that when we place a graft material on the extractant socket, we see a significant improvement in both horizontal and vertical bond reduction, comparing to leaving the socket to heal naturally. Biomaterials serve as a scaffold to facilitate bone formation. Bone grafts, however, will lessen the resorption but will not prevent it completely. There is a net horizontal bond loss of 1.5 millimeter when bone graft is placed, as compared to almost 4 millimeters of horizontal bone loss if the socket heals naturally without graft, and also significant less vertical bone loss. This is a rationale for intra-socket grafting for socket preservation. However, in the aesthetic zone, the 1.5 millimeter still makes a big difference in the final result. So that's why we often need soft tissue augmentation when we do immediate implant with bone graft inserted in the buccal gap. In addition, thicker peri-implant soft tissue appears to have a positive effect on the crestone bone level. An implant treatment guide has suggested that the safe zone for implant placement is within 1.5 millimeter of a lingual to a tangent line connecting the root surface of the adjacent teeth. For immediate implant, this so-called safe zone is not safe. In the buccal bone modeling will end up just palatal to this zone. Placing an implant there will have a high possibility of the implant losing its buccal bone support and thus resulting in tissue recession or bone dehiscence. In my opinion, the whole buccal zone should be considered danger zone, and an implant should be placed away from this zone. There are two ways to help your implant minimizing to maintain the sufficient bone buffer on the buccal aspect. Choosing a smaller diameter implant and placing it more palatally. This palatal position is also facilitate fabrication of the screw-retained crown. Now, the smaller the diameter of the implant and the more palatally it is placed, the deeper the implant must be placed to maintain the buccal emergence profile. This means subcrestone placement. The concept of subcrestone placement is pertaining to only a limited number of implant designs. We know now that bone will go down to the level of rough surface in the tissue level implants and go down to the first thread of the micro gap in the flat design. And thus, these implants may not be good candidates for subcrestone placement. So choose the implant system for the immediate procedure. And I will elaborate on this concept in my upcoming tissue level lecture if I would not cancel them again. Ideally, the vertical soft tissue should be between 3 to 4 millimeters, according to Tomasis and Linkevicius, allowing 2 millimeters of barrier epithelium and 1.5 millimeter of connective tissue attachment. Unlike the buccal bone plate, which is made up of mostly bundle bone, the palatal bone has a thicker layer of cortical bone. The thicker bone and soft tissue in this zone may account for less tissue loss in this region compared to the buccal side of the extraction socket. This region is hidden behind the implant crown, so any asymmetry compared to the tissue contour from the adjacent natural teeth shows less aesthetic impact. An immediate implant placed against the palatal bone also helps with implant stability. The proximal or papillary zone. The tissue lost in this area compromises the shape of the papilla, thus affects the aesthetic outcome. In natural dentition, the shape of the papilla is decided by the height of the proximal bone and, of course, the distance between the roots. It has been observed that in natural teeth, the papilla are always present if the vertical distance from the proximal bone to the proximal contact point is within 5 millimeters. But more than that, we start to see the loss of papilla. By knowing the interproximal bone remaining on the adjacent natural teeth, the final papilla level can be predicted, and this is a very important factor in treatment planning in the aesthetic region. In this example, meso and distal papilla are filled nicely because the distance from the crest of the natural proximal bone to the proximal contact area is within 5 millimeters. Notice, however, that the proximal crestal bone at the implant shoulder is a lot more apical, which brings us to the observation by Joseph Kahn. The height of the papilla is dependent on the level of the proximal bone of the natural teeth, but not that of the adjacent implant. So an implant can be placed deep, and you will not lose a papilla if the proximal bone height of the natural teeth is within 5 millimeters of the contact point. For adjacent implants, however, obtaining optimum papilla height is usually less predictable, since the behavior of the peri-implant soft tissue is still not fully understood. The factors that determine the final contour of the inter-implant soft tissue might include, but not limit to, the distance between the implants, the bone volume between the implants, the vertical thickness of the gingiva, the shape and profile of the transmucosal abutments, peri-implant gingival health, and properly the design of the implant abutment interface. Apical zone. A high percentage of hopeless teeth that need to be removed involve periapical abscesses or granuloma. Evidence suggests that an implant can be placed into an infected site following a thorough debridement of the socket. And sometimes apical surgery together with the implant surgery is needed for proper debridement. The apical bone provides the most initial stability for immediate implant. Sufficient bone height and thickness beyond the root apex is necessary for implant placement. So choose the implant long enough to engage the apical bone when you place an immediate implant. The most common mistakes is that sometimes on the x-rays we choose an implant length but end up sinking the implant deeper than planned in order to obtain primary stability, The reason is that the implant is placed too deep. This could be prevented by planning a longer implant ahead of time. Another important consideration is when placing an implant, an immediate implant or even regular implant, is the direction of the axis of the implant. Ideally, sorry, I have to stop to admit some people. Ideally, we want to place a screw hole in the cingulum for the screw retain crown. But since the shape of the alveolar process varies greatly, the implant has to go where there is bone. And thus we have sometimes accept a cement crown. And also osteotomy, therefore, needs to be considered on a case-by-case basis. So now we should take a few minutes for questions. If you have any questions, please submit to the chat window. And I can. Hello. I have a question from Panagiotis, or just a remark. You can unmute to ask question. Panagiotis said the connection is too close to the bone. I would prefer a higher abutment. That's right. Many of my cases are done many years before. And I'm still learning. Some are very stable. Some start to see a bit of bone, crestone bone loss because of the connection. Because the connection is close, that means the immersion angle is very wide, and that is one of the reasons to cause bone loss. So when we look back at we learn when we look back at the X-ray and photos. Thank you, Panagiotis. Question from Natalie. Natalie, you want to ask your question, Natalie? You can unmute yourself. Natalie.
Yes, Ben. Yes. Actually, I'm wondering, there's two ways actually when the implant has to be placed more buccal and not as parallel as wish. We have a deangulated screw channel that we can use to still do a screw retained crown, or we can cement a crown with a custom abutment. Is there one better than the other? And because when you have a custom made abutment with the finish line above or at soft tissue level, there's not much risk for the cement to be left underneath under the soft tissue. So I was wondering, is there one that you think that is really better, or is it equal in your opinion?
When you mean the implant was placed more buccal, you don't mean the shoulder of the implant is placed near the danger zone that we mentioned before.
No, I mean
that the axis of the implant
is more buccal. Yeah.
That means the shoulder of the implant still have a bit like a millimeter, 2 millimeter away from the buccal bone, right?
Yes, yes, yes.
Yeah.
But the picture of the angulated
Yeah.
ridge, we could see, that you have to place the implant more with an angulation more, so it comes out like buckle or at the incisor ledge.
A lot of
So
time we cannot, we have no
yeah.
choice. The ridge is very flare, so we have
Hmm.
to follow that. And I encountered so many, and
Exactly.
the best way to do there's actually no best way, but for the like we mentioned about the what Panagiotis just mentioned, the connect the connection, the joint between the for the ASC, that means screw channel,
Angulated screw.
angulated screw channel. I usually see that it brings the prosthetic part, which is either the ceramic or zirconia or titanium cap, very close to the bone.
Yeah.
They don't have a flexitive like a custom made abutment or a stock abutment that you can choose the abutment that is very slender with a less with less uh, open emergence angle.
Yeah. Yeah.
I prefer to
Cemented. Yeah.
have a cemented stock abutment. However, I I like to ask my lab to have to make the abutment in zirconia with white, bringing the margin of that zirconia up to the same level of the gingival margin. So at
Yeah.
that time, we can control it perfectly because
Yeah.
they can either wax it up and cast it, or they can do it in computer. They bring the level up to the gingival margin, and when you cement, you can control the cement really well, and that works really well with my immediate
Mhm. Mm. Good. Thank you.
Sami. I hope I understand.
Hi.
Answer
Yeah.
your question, Natalie. Sami,
Yes. Yeah.
yes.
So the reason why I asked this question, I do have a case of a primary canine I'm planning to replace with a permanent one. It's the tooth number 83, and it's a mandible. The bone is kind of narrow. I'm gonna use a 2.9 Strowman. It's a little bit more constricted and the middle segment of where the implant I want is going to be placed. So I wonder if we get close to the cortical bone, like towards the apical of the implant itself, would there be any risks here? Do you think it's safe to do that within the body of the mandible?
I see so many perforation, you mean, right?
Like if I stay within the bone, do you think that would be still okay, even if I'm close to the cortical bone itself?
On the apical part, right?
Yeah, towards
I see
the,
so
the
many
bottom.
perforation of the cortical bone from the apex. It's really sometimes extensive, and the implant can stay very long.
Hmm.
So the softish, that part is not problem. It doesn't cause any bone loss. The
Okay.
problem is the crestone bone loss.
Hmm.
So sometimes you have a very strong cortical bone on both sides of the, like a narrow mandible, but corticals are very strong.
Hmm.
You have to do it by hand and feel slowly, feel the cancellous bone, and you just follow that without even care like what you have to cement or screw, because
Yeah.
you have too narrow. You have to follow that and just do use the rotary ostotome like a denser bird that will not cut the bone, but go reverse. It's very light, easy to, sorry, I have to admit somebody. Admit doesn't mean put them in the hospital. So you follow the bone softly and you just, you don't, usually because the corticone is so strong and in the heel ridge, you might not need to, and especially like in a primary teeth, the root are so small, so it's basically consider heel ridge. The corticone bone, if you're close to it, you might not, it might not be lost, the corticone bone. So you can do that. You can follow gently, reverse cutting. So you have a very precise placement. But maybe you have to do the, like I said before, cement crown.
So in a case like that, do you find yourself, if you don't have a guide, do you find yourself having to flap to see better?
Oh yes, I would not like to do flapless unless it's an immediate implant, because the primary, if you feel that you can have a control, sometimes, you know, I have to even, if you don't do flapless, you do want to do flapless, sometimes I open a small window in the apical area to control my placement so that I make sure my implant is not perforated.
Mhm.
That is, but the healing is very easy, very soft. I just open it to see, to follow. And sometimes there's like a case before there's apical pathology. I take it out, I scoop it out, the granuloma, and then I can see the apex of the implant. So I know my implant is in good position. But the most important is the thickness of the buccal bone always. So if you're in doubt, graft that, like a contour augmentation.
Mhm.
But you have to understand that when you put a graft material, you will create some inflammation and you will help losing a bit of corticone bone. But if the corticone bone is thick, it's not a problem. Okay? But
Hey,
but
so hi, thank you. So the question is that in immediate cases, sometimes the tooth root could be extremely long, and the only way to have stability is to put a very, very long implant. But for it to come down on the lingual side, the cingulum, you end up having towards the buccal a little bit, and you thin out the apical buccal part. At what distance do you need minimum requirement of implant engaging in the apical bone to decide if you're going to do an immediate implant case or you're just going to do some sort of preservation and come back later? What is your thinking in that?
that's a very difficult question to answer. So people usually they said 5 millimeters. Who can dictate how many millimeters, right? They said 5 millimeter. Most of the guru would say 5 millimeters, but then it depends on how soft the bone is and how, you know, how to engage. If it's strong, maybe you even need less. But then you should choose an implant so that it just, because the socket is tapered, so you might need to engage a bit of bone there, the apical, but sometimes you can engage more socket up higher up coronal than that. So you have could choose an implant with a more aggressive aggressive
Threads.
thread. And I've done a lot of BLX now, and I'm very confident and find that it's a good implant to put because it's ripped very well, and you need very minimum preparation. Okay. But if the implants go in toward the buccal, then you have to do a cement retain. And don't just take a stock abutment and just put the cement in, because for sure you lose that implant, because there's no way you can remove the cement. Okay. So do the two, like a abutment, a custom-made abutment in zirconia, that's best because it's more compatible with soft tissue. So, and then bring it up to the level of the gingiva and then cement it and have better control.
Thank you.
Question? If everybody's okay, I can continue now. Timing for implant placement. We have 4 implant placement protocols which have been proposed by Hammerly in 2001 with additional terminology later by Chan and Boozer in 2008, which is based on the healing of the extraction socket. I will walk you through these protocols by using case studies to also show how I treat these cases. And in immediate implant, ridge preservation principles are used to prevent or minimize the dimension loss before it occurs. In type 2, epithelial tissue has proliferated to close the socket. At 3 weeks, osteoid is mineralized to become woven bone, and at 6 weeks, the woven bone has filled most of the socket. This immature bone is very soft, but the healing potential is great because remodeling process is starting to convert this bone into lamella bone. In type 3, the majority of the socket is filled with lamella bone with the complete formation of bone at 4 months. The hard cap of corticone bone has formed to cover the socket at the beginning of this period. The bone is still soft, but usually strong enough for implant stability. After 4 months, most of bone remodeling has completed and mineralization will continue with time. The term delayed placement is when it's not immediate, such as in type 2, 3, and 4. Because the tissue loss has occurred, preservation is no longer possible, but we have to rebuild the lost morphology. The longer the placement is delayed, the more tissue loss will occur and more reconstruction has to be done to restore the ridge. In addition, addition to the confusion, some authors use the term post-extraction placement to refer to type 1, 2, and 3. Try not to use this term because it's too vague. I will start with type 4 before and continue with type 1, 2, and 3. Sorry. Just want to check to see if somebody's checking in, and it's very difficult, these things. So this is type 4 is when an implant is placed in a full heel ridge at later stage than 4 months after the extraction. Indications: long time edentulous, or when a delay in implant treatment is anticipated due to pathologies associated with tooth, such as large abscesses that take a long time to heal, or when the patient is not ready, or when the primary stability cannot be achieved with type 1, 2, and 3 placements due to anatomical restrictions such as sinus or nerves, Thus, you need to wait for bone to completely mineralize for added primary stability. The advantage of type 4 is the healed and matured, full mineralized bone provides better implant stability. More soft tissue volume allowing better flap closure for rich augmentation. Pathology related to the extraction tooth has been resolved. The disadvantage, the majority of bone loss has occurred, thus limiting the bone volume for implant placement, thus require more complex augmentation. Type 4 is usually require longer treatment. So this is an example of a late placement type 4. This patient has lateral incisor removed many years back, but only recently could afford an implant treatment. He was wearing a bonded resin bridge. You can imagine underlying atrophy just by looking at the buccal concavity of the ridge. And now we have about 4 millimeters of ridge thickness at the crest. You can tell the tooth has been removed long time ago by looking at the new cortical bone formed to cover the buccal surface. So the implant preparation was done using denser burrs, which run in counterclockwise direction to condense the bone and to minimize bone removal. This company may advertise that the burrs expand the bone, but I haven't seen any significant ridge expansion using these instruments. So we can see here that 40% of horizontal ridge dimension was lost. The implant is placed toward the palatal aspect, as I mentioned previously. A combination of small diameter implant, more implant placement, more palatal placement, and modified implant preparation by using denser burrs helps to maintain 2 millimeters of bone thickness labial to the implant. So we have a 4 millimeters original ridge width. We put 3 millimeters implant, and we still have 2 millimeters buccal bone thickness. So can you do the math? Why? We have 2 millimeters of buccal bone thickness, and we have 3 millimeter implant, which is 5 millimeters, and we have only 4 millimeter of ridge. It's not because the bone is expanded buccally, but because I sink the implant deeper. So the deeper the implant goes, the more buccal, the more thickness of the ridge that I can play with. So in this case, we put a GBR procedure with just to augment the labial contour of the site. Notice that the implant is in the natural bone. The bonded bridge was used as stem. In type 4 late placement protocol, the soft tissue architecture has changed with time. The papilla are usually flattened. In this case, in the distance between the proximal contact point and the proximal bone of the adjacent natural teeth is within 5 millimeters. So with a little manipulation of the soft tissue during the temporization, there is a good chance that we can rebuild the papilla. At the second stage surgery at 4 months post-op, there is usually some graft shrinkage which will require soft tissue augmentation procedure. So instead of a complex soft tissue augmentation, we use a buccal rolling flap in which the keratinized epithelium is removed, and this small flap was formed under the labial soft tissue and sutured to the buccal tissue. The screw retent hem was fabricated chair-side with proper emergence angle. And at final impression 8 weeks after, the papilla start to grow back to adapt to the emergence profile of the temporary crown. Remember this configuration. Small diameter implant placed 3.5 to 4 millimeters subgingival margin. We achieve 5 to 6 millimeters of buccal tissue thickness, allowing 2 millimeters of soft tissue and 3 to 4 millimeters of buccal bone. And final crown in place. There's a bit of missing distal papilla, right? Because the distal proximal bone is lower than the mesial bone. I'm showing you this example in detail because it is simple enough for most of you to manage in many of your cases, but not all type 4 are as simple as this case. Type 4 patients may show up with different degrees of atrophy, and different treatment options can be selected to treat them, such as ridge splitting and expansion, bone grafting procedures, including GBR, onlay inlay block grafts, alveolar destruction osteogenesis, nerve lateralization, short implants, and a combination of tilted and axial implant placement for full artery restoration, or even mini implants in very selected situations. Many of these cases may require staged approach. For example, in this case, ridge splitting. I'm missing a slide. This case, autogenous bone graft harvest from ramus with shell technique to augment the buccal aspect of the first premolar. An example of complex treatment involves sinus floor elevations, bone grafts, and short implants. Or simplified graftless treatment options such as all-on-4 procedure protocol, zygomatic or subperiosteal framework implants. Wait, missing something, just black. A patient can come up with severe structure deformation to iatrogenic factors. And the more complex the situation, the less predictable the treatment results. Not all of us are comfortable treating these complex cases. However, it's within our ability to help minimizing ridge remodeling by offering more simple ridge preservation procedures. I will quickly talk about ridge preservation because it's relevant to the topic of treatment plan timing. Oops, something serious happening. Sorry, I keep missing slides, so there might be problem with Socket preservation. When talking about ridge preservation, we commonly refer to alveolar socket grafting. But the ridge preservation should also imply other procedures as well, like orthodontic movement, extrusion, or lateral displacement of a healthy tooth can bring bone along to fill the socket space. Placing a biomaterial on the external wall at the time of extraction has also been reported, but the graft doesn't help to prevent the resorption of the buccal corticone bone. Root submergence can also be done for ridge preservation under a pontic. The crown of the tooth is cut off, leaving the root buried under the gum. Soft tissue will grow over the root, and there has been reported of bone growing coronal to the root. Periosteal inhibition technique is a novel preservation procedure with application for immediate implant as well. But the majority of the socket preservation involves alveolar socket grafting. Alveolar socket grafting for ridge preservation is a procedure in which biomaterial is placed inside the extraction socket, usually done with an occlusive membrane to keep the graft in place. A stable membrane serves to hold the graft particles in place during healing time. Rapid resorption membranes, such as collagen...
Sorry, doctor, we don't see the keynote. We don't see the slides.
I'm sorry. Crazy.
I see them now.
Yeah. Got it?
Yes, visible. Thank you.
Sorry about that. Usually the resorption rapid resorbable membranes such as collagen membranes and blood membranes will disintegrate long before the hard cap formation. And this will affect the coronal volume of your ridge. My preferred occlusive membrane for intrasocket grafting is the 3-gingival graft or the socket seal, or a PTF membrane. The efficacy of socket grafting is well documented. There is significant reduction, but it does not prevent loss of ridge dimension completely. We observe around 1.5 millimeter of horizontal bone loss with ridge preservation versus 4 millimeter of horizontal bone loss when the socket is healed naturally. So what does 1 and 0.5 millimeter of horizontal bone loss imply? It means that the buccal corticone bone plate is gone. Remember, more than 80% of population have less than 0.8 millimeter of buccal corticone plate. Socket grafting thus doesn't prevent the resorption of the thin corticone bone plate. These are facts about socket grafting. The ridge preservation doesn't appear to affect the success rate of implants. However, the effect of the grafted bone on the long-term survival of the implant is still not well understood. A study on animals comparing grafted socket and non-grafted socket as control, it shows that the early healing stage, which is around 2 weeks post-extraction, the bone grafts shows a typical foreign body reaction with the xenograft particles enclosed in connective tissue and surrounded by multinucleated cells, when at the same time in control group, non-grafted size woven bone has occurred most of the socket. After 3 months, in grafted size using xenograft, only 12% of new bone is found. versus 50 to 60% of new mineralized bone found in a non-grafted socket. So the authors concluded that the grafted bone substitutes interfere with natural bone healing response. 25 to 35% of residual graft particles are found in the grafted socket at the time of re-entry. Biomaterials vary, healing times vary. Xenograft or allograft may take between 6 to 9 months. The particles of biomaterials may take a long time to resorb. In fact, they may remain indefinitely. So no one biomaterial or technique is better than another. Socket grafting fails to completely prevent the resorption of buccal or bone walls. In conclusion, socket grafting doesn't completely prevent the loss of rich dimension, and hard and soft tissue augmentation may be required for implant placement, especially in the aesthetic zone. Long waiting time, high residual graft particles, and additional costs are drawbacks. To overcome the drawbacks of biomaterials, other techniques of intra-socket grafting can be used, which allow natural bone formation within the sockets, such as the free gingival bone graft. With this technique, host bone can be used in the form of block graft, harvest from the tuberosity, which allow fast integration of the graft. So in this case, the whole buccal bone wall was gone due to infection. A cylinder of bone and soft tissue is harvested from the tuberosity using a trephine, ready to integrate to the recipient site. No occlusal membrane is necessary, and mature bone can be found at 4 months, ready for implant placement. I do this technique when there is a large buccal or lingual dehiscence observed in the extraction socket. The bone cylinder is inserted in the socket and put interrupted sutures to hold the graft in place. After 4 months, an implant was placed. The bone formed inside the socket was solid enough to give good primary stability. A gingival former was fabricated at the time of implant insertion. At this stage here, the site is ready to receive the final crown. In this case, both bone and soft tissue is well preserved. The reason why I put a gingival former because the patient is undergone Invisalign treatment. So we don't want to disturb the Invisalign treatment by putting a temporary crown. We wait for the Invisalign treatment finished before we can place a crown. But my favorite socket preservation of all is invented in Quebec, periosteal inhibition technique. This technique is done when the buccal bone of the extraction socket is intact. High-density PTFE membrane is placed between the buccal bone and the periosteum. This non-resorbable membrane appears to inhibit the formation of osteoclasts on the bone surface and thus prevent modeling of the cortical bone plate. No bone graft is needed. Blood clot alone is allowed to fill the socket to facilitate natural bone formation. What you see here is a piece of gelatin sponge placed loosely to help stabilize the clot. In this situation here, the monofilament non-resorbable sutures were used to close the flap. The suture went through the corners of the membrane to keep it in place in this case. At 4 months post-op, ridge width and height is well preserved. A 90-degree angle is typically formed between the intact cortical bone plate and the occlusal bone surface with this technique. This phenomenon has never been reported in any other socket preservation technique. Now I will continue with type 1 immediate placement. But before that, maybe any question? Any question on type 1, type 4 and socket preservation?
I want to ask about the last case you posted, the one with the membrane. So you packed a gel foam in the socket and you didn't, and it slowly became bone tissue.
Alan? Alan? Yeah. Hello? Is that Alan?
That's Sammy.
Sammy?
Yeah. So you packed gel foam in there, and
This is the gel
became,
foam.
yeah.
Basically, we have nothing. We just remove the tooth. You can see the bone here.
Mm-hmm.
You can see the socket of the meso and distal root here. The bone is exposed even. So I don't really concern about the inside.
Mm-hmm.
The blood will fill that. Okay.
So hypothetically, my question is: let's say if we have an interior socket, and we took out a tooth, and we're planning to immediately place an implant in there, and the question is, would it be better to just leave the socket and let it fill with the blood clot, or can we enhance on that by adding gel foam if we did not choose to go with a bone graft?
Okay. You are talking about socket preservation just in this case, or you want to put an implant in there?
Let's say if we place the implant and we choose not to put a bone graft in the buccal space.
Yeah. I still consider nothing. I still let the socket heal as if like natural healing, because that's the best way of healing in my opinion. So basically the bone will filled and whatever. So the space around that implant, because the implant will be smaller than the socket in this case, right? The space around the implant, I will put gel foam. If you want to have a gingival former, it's okay too. As long as something to prevent, the food from like rinsing the socket out, or, can cause the socket.
So a gel foam is not a bad thing to pack in the space.
No, gel foam is a material that used maybe 100 years. It's the oldest material used by oral surgeon, and we use that when we went to school. We took out a wisdom teeth or something. We put a gel foam in. The rate for the gel foam it's melted away very rapidly, but at the first 24 hours is when it's crucial for the blood formation, clot formation. It helps to stabilize the clot. Now, if you don't want to put, it's fine. If the blood is healthy people, young people, and the blood will fill in and close the socket, it's fine. You don't need that. It's just an additional measure, because my rationale is that when the bone, if the buccal bone is protected, then the bone has no way to do but fill itself. Nature will fill the empty void. Okay.
Okay, thank you.
Does it answer your question?
Yeah, I just wanted to make sure that, because somebody told me, like an oral surgeon from Brazil told me that you don't want to pack gel foam in a socket, and he didn't tell me why. So
yeah, in
it's
some
important.
studies, gel foam appear to interfere, but not very strong evidence. It's still, you know, we prefer blood clot, but sometimes we try, you know, we try to avoid socket, dry socket, stuff like that. A lot of time when the socket is small, the vacuum space is small, I don't put gel form. If I know that the blood feel nicely and I have a temporary crown, I don't put any gel form in there. But I haven't seen any problem with that gel form. It's a very interesting material, cheap. I even use it now to augment some gum. Very efficient. Yeah. So don't worry about it. It doesn't it doesn't seem to promote bone formation, but it doesn't really interfere with natural healing because it melt away, you know, maybe 24 hours. Okay.
Okay, thank you.
Is there anybody, because I can't see the chat forum? Any other question? Anybody happen to see in the chat forum to see if there's anybody, any question?
Yeah, I have a question, Dr. Win.
Who's that?
Manuela.
Hi, Manuela.
Hi.
Yes.
Can you use this if you perform an immediate implant at the same time, at the time of the extraction?
For the periosteo inhibition.
The periosteal inhibition technique, yes.
Yeah, inhibition, periosteo inhibition. I am doing a big study on socket preservation because that's just like a standard. If you can pass through that, then immediate implant is just it need document from socket preservation, right? So when we have immediate implant and we put we put graft in the sockets, right? And that is following the intra-socket grafting. So for me, when I do treatment now, I do immediate implant, especially in the aesthetic zone. I don't preserve unless I don't have a stability to put an implant, yeah, like a big periapical, whatever, but the intact buccal bone, I will put a membrane there and wait for it to heal like that. But if I have a chance to put immediate implant, I will.
Okay. So you don't use this technique when you do the immediate.
Yes, that's what I just said. I use mostly immediate. So you will see more cases coming with this technique also. Okay. Do you see any other people want to ask question? Stephanie, Tiffany?
Yeah, I have a question about the membrane. You put the membrane between the buccal plate and the flap, so you have to make like a full thickness.
Yes. I when I do this study, I do the full thickness, but it's not a it's a full thickness, but it's like an envelope envelope
Flap.
flap, and
Yes.
sometimes I have to cut to open to separate the papilla by some papilla preservation incision, so I can see more. This technique is some people do it, it works. Some people do it, it don't work. It doesn't work because if you don't separate the periosteum from the bone, you have to make sure you do that. Then you will lose bone because the periosteum is a source of blood vessel that will bring the osteoclast precursor into the area which become osteoclast. So you have to make sure you flap the periosteum away from the bone. That's just pure bone before you can put a membrane.
And how long does it have to be the length of the membrane? I mean, that you have to cover until the apex of the tooth?
No, just like a socket shield technique. If you understand, you remember the socket shield you cut the root and you leave the inside of the root like 2/3 of the membrane. So you just want to preserve the buccal plate
Mm.
and the buccal crestone plates. So you just need 1/3 of the socket, and you minimize it into between the line angle of the socket. So you don't want to make it too big, because the bigger the implant, the more the corner will cause the perforation of the membrane, which is one of the drawback and one of the risk. And
Mm.
maybe we'll do another lecture on this later on. Okay.
Yeah.
Does
So
it?
you don't have, yeah,
Okay.
so you don't have to cover the root of the adjacent teeth.
No, we
Yeah,
don't.
just
don't.
only,
Yeah.
yeah. Okay.
Because up to now, we're always concerned about the crestone bone
Mm.
around that. Yeah. And also, as you go more apically, the bone becomes thicker.
Okay.
The thicker, you might not lose that much bone.
And you let the membrane for how long?
4 months.
4 months.
Yeah.
Okay.
I will continue with this, and because it will repeat some of your question, but yeah, you are welcome to read the article that was published, and it was on the Montreal Society of Implantology website.
Mm.
Okay.
Okay, Vin, I have a question. It's Natalie.
Yeah.
Is there a reason why you didn't put a suture to hold the membrane for 4 months on this case?
Yeah, this is one of the original cases. Actually, this is one of the cases how I discover. So I just put a membrane there. I did not develop the protocol clearly.
Okay.
I use a buccal suture, very thin polypropylene suture, to remove the to leave it there for 4 months. Okay. So now I'm going to continue with type 1 immediate treatment. The immediate treatment is done at the time of tooth extraction. It can be done flapless if the buccal plate is intact. Especially done in the aesthetic zone, this protocol allows quicker placement of the extraction tooth replacement. The advantage is the implant placement is done at the same time as extraction. Short treatment time, usually 4 months. Implant placed in a four-wall socket with maximum osteogenesis potential. Minimum hard and soft tissue alteration has taken place that give you the chance to preserve the structures. The disadvantage, technique sensitive, difficult to achieve primary stability, lack of tissue for primary closure, and mid-facial recession is a risk. In this example, the patient has root caries, loss of a Posen crown, and the buccal plate is typically thin. A perioapical lesion is observed with possibility of buccal bone fenestration. So in this case, apical surgery was done to thoroughly debride the apical granuloma. When you see a socket that's very narrow, it's very hard to curate 100%. And if you have any doubt, open a flap apically and just to make it clean easy. So you can see in this case, you put an implant there. In this case, a bio-os was placed in the buccal space. You see my arrow here? Do you see the arrow? My arrow? My pointer? Yeah, we put only bio-os here. We don't put bio-os there. This hole here was covered by a bio-guide membrane and just closed like that for the blood to form. But we put bio-os here. This is follow the principle of intra-socket grafting. Screw-retained temporary crown was fabricated, and the connective tissue graft harvested from the palate was inserted under the buccal gingiva through a partial thickness tunnel. This is 3 millimeters diameter implant. And soft tissue training with a temporary screw-retained crown. And same configuration of implant placement relative to its surrounding hard and soft tissue at 4 months post-op and at the final impression material. This immediate protocol used bone graft placed in the buccal space is popular at the moment. It is almost always accompanied by soft tissue graft. It follows the principle of intra-socket grafting, socket preservation. I don't use many of them anymore. Now, if you only do intra-socket grafting for immediate placement, we know now that there will be 1.5 millimeters of horizontal net bone loss, which translate to buccal concavity and dark shadow of the soft tissue. This volume deficiency is observed equally on both thin and thick gingival biotype. So we often place a buccal soft tissue augmentation in the form of a connective tissue graft to help compensate for this deficiency. This is confirmed by these two studies in 2012. This is an example of variation of immediate implant, the socket shield technique. Although little long-term evidence has been documented, the socket shield technique has clinically shown good promise in maintaining original rich contour. This technique was introduced by Zeller and co-authors in 2010. The root of the tooth is sectioned in such a way that a thin fragment of root or the shield is left attached to the buccal bone while the rest of the root is removed. As the labrum periodontal attachment is left undisturbed, no osteoclastic activity seems to be triggered labial to the shield. An immediate implant is placed in the same protocol described previously, but without additional bone or gum graft. Implant placement followed the immediate protocol. Small diameter implant, palatally placed, subcrestal placement, immediate temporization. No grafting is necessary in the buccal gap and no soft tissue graft. And at 4 months post-op, the same tissue configuration as seen previously. The preservation of the papilla is unpredictable between adjacent implants. In this case, in this double socket shield technique, I was lucky enough to preserve the papilla in this aesthetic zone. The root fragment was left in place, thus preserving the whole buccal periodontal complex. But this is a time of final impression. The result of 2 immediate socket shield placement on the left central and lateral incisors with the buccal contour unaltered. This was done without bone graft nor soft tissue graft. Five years result radiograph. This is periosteal inhibition technique. It's a variation of immediate implant placement. I follow the periosteal inhibition for socket preservation mentioned earlier. An immediate implant was placed in the second premolar socket. A high-density PTFE membrane was trimmed and placed against the buccal bone under the periosteum. Notice the buccal bone place is paper thin. No bone graft was placed in the socket space and no soft tissue graft was performed. Only a piece of gel foam was placed to cover the socket to stabilize the blood clot. This is a ridge after 4 months. 90-degree angle is observed between the buccal and occlusal bone surface. Bone has completely grown over the implant. I had to use a blade to dig it out, to dig the implant out, which was buried under more than 2 millimeters of bone thickness. So in this case, we can see that the gel form was not did not affect the healing of the natural bone. This is after the soft tissue has healed and ready for impression. Observe the soft tissue thickness without any soft tissue graft. I have to stop the share because something's going on again. Email that you can see. Black. Anyway, this is another case. The upper left lateral root was fractured. A small slit was made to clean the apical granuloma and check that the implant was placed without perforation through the buccal bone. The subperiosteal tissue tunnel was done coronally from the incision and the membrane was inserted in the tunnel. The small slit was made first, but I realized that it was too high in the vestibule, thus makes it difficult for me to prepare the tunnel. So I made a second slit more coronally. An accurate implant position. This is the final crown. The final ridge contour. We now can compare with the pre-op photo. You see that there was minimized a minimum ridge alteration. This is the before. Any question on type 1, immediate placement?
Vin, in the socket shield technique,
Yes.
can you hear me? Why is it so important to remove the apex? And would it be a good idea to do a little opening, just like you were doing at the buccal at the apex, to make sure you remove everything over there when you do a socket shield. I know you don't do them anymore, but I'm just asking, what do you think?
Joseph Kahn had an article on this when he used a few patients, a few case presentation, and he showed the apical surgery done at the same time or as the implant placement and socket shield. First of all, it's easier to because it's very difficult socket shields. Sometimes very small, and the root sometimes very curved, and there's no way you can remove them except make a hole apically and remove them surgically. At the same time, you clean out the infection. You don't remove the root. That's why I am a bit hesitant to join the socket shield group Facebook, and because a lot of people just do anything, especially even they do it in molar, premolar, and I find it so hard to do with one root. Imagine many roots. So people think that they can do that and leave the root tip alone. But well, sometimes you can get away with it. But if you have a tiny infection or apical infection, you will lose that shield. Because imagine the infection, and then one will never heal, then it will spread up to the coronal area. So when you do a shield, you just borrow a piece of dentin, but you don't want to have vital pole or necrotic pole inside. Cause a problem. So if you're not sure, don't leave anything except the shield, right? It's just if you can get. So people can put a few cases up and it looks okay, but you can see it will not stay long, and it will cause a problem and bad result for the technique, which is very, very interesting and very novel. I believe in myself that it works very well, because some of my cases had done like even 9 years and still okay. But there's report of like some shield is lost because of infection. Later on, many years later, the shield just pop out, slowly moving out. I have the feeling that when there's infection, there is something boiling in there. You cannot see it, and you leave soft tissue in there, and that's it. It's just some go against the implant treatment principle in with this. Manuela asked if you can use this periosteo inhibition technique with immediate implants. I answered that. We will do that later also. Okay, nobody seemed to have any question.
I have a question.
Yeah.
I'm sorry, Dr. Vid.
Go ahead.
In your case, that posterior tooth for immediate implant with PI on the premolar, do you always use a cover screw 0 millimeters? Or do you happen sometimes to put a healing abutment of 2 millimeters and avoid digging it afterwards?
Yeah, that's my experience. I have to dig out the implant. So now I put like a two, because I put my implants usually subcrestal a bit, so it's around 3.5 to 4 millimeter under the gum line, which is about 3 millimeters from the adjacent CEJ. So the same. So in that case, I put a healing abutment. I buy healing abutment 2.5 millimeters, so it can be a bit up or flush with the gum. That create a very beautiful, easy to manipulate. But if I have a chance, I put a temporary crown, which is a lot easier after to work. Okay. We continue. Now we talk about the type 2 early placement soft tissue healing 4 to 8 weeks. The type 2 is done 4 to 8 weeks after the extraction. The indications is active infection contraindicated for immediate implant placement, or bone graft procedure, bone grafting procedure is anticipated, especially, for example, extensive bone loss in the buccal plate. And this will allow soft tissue to cover the socket opening with keratinized gingival tissue, thus facilitate primary closure over the graft. I will elaborate on this point after when we show some example. Advantages. This early option is chosen to avoid further bone loss and reduce the treatment time comparing to type 3 and 4. Additional soft tissue volume facilitate flap closure and soft tissue management. Resolution of pathology associated with extraction tooth. The site has high osteogenic potential during the early healing phase of the socket. The disadvantages: longer treatment time comparing to immediate implant, additional hard and soft tissue augmentation procedures, and we only have soft tissue healing here. The bone has not healed yet, may not have enough initial stability. This is an example of type 2 treatment. Root fracture and infection caused complete loss of the buccal and palatal walls. The tooth was, the infection was so extensive that the tooth was just extracted, and after 6 weeks, the socket is closed. There is an increased amount of keratinized tissue. That's also a rationale for this technique option. The large vertical defect, in this case, we might not see more bone loss if we waited another year, because the bone loss is quite extensive already. So why should we start now? Of course, if the patient wanted to have her tooth replaced as soon as possible, but the important rationale here is that the socket is still fresh. The bone lining this wound is cancellous bone with good blood supply, and thus can provide high angiogenesis and osteogenesis potential. An ankylosed implant was placed in a proper depth. That means around 3 millimeters apical to the adjacent CJ. It was placed in a proper buccal lingual position mentioned before. Sticky bone with xenograft was placed to augment the defect. And the GBR protocol was done using BioGuide membrane and bone tacked over the graft. And PRF was also used in this case, and added thickness to soft tissue. This is at 8 months post-op. A temporary crown was made to shape the soft tissue. Notice the buccal roll flap. I try not to waste any soft tissue, especially in the aesthetic area. Anyway, a temporary crown is placed, and So this is the result at the time of impression. This is a final crown. It's very difficult case actually. A very good profile. So now we talk about type 3. Type 3 is done between 3 to 4 months after the extraction. At this stage, significant bone field has occurred. Although remodeling process is still going on, soft tissue healing has completed. Significant resorption of the buccal bone place has occurred. Why we need to wait 3-4 months or more instead of using type 2 protocol? Maybe the patient is not ready, or maybe you want to be sure the infection is completely gone, or you may feel that increased bone quality gives you better stability for implant placement. Advantages: increased percentage of lamellar bone allows primary stability. Soft tissue completely covers the socket opening, creating additional soft tissue volume, facilitating flap closure and soft tissue management. Resolution of pathology associated with the extraction tooth. Disadvantages: additional procedures, longer treatment time comparing to type 1, 2. Increased horizontal bone resorption may limit the bone volume available for implant insertion. In this example for type 3 placement, the patient had vertical root fracture with lateral periodontal abscess. We had to wait almost 4 months for the patient to decide on his implant treatment. We usually expect soft tissue type, soft bone type 3, 4. We often expect to see 25 to 40% bone loss. The cortical bone has formed to cover the occlusal surface. So now we have soft tissue, soft bone and thin bone. What should we do? Think of bone condensation under the unprepared osteotomy, longer implant to engage apical bone, and expect hard and soft tissue grafts. This is a pre-extraction radiograph. Is there a chance to maintain papilla? The proximal bone level of adjacent natural teeth is more than 5 millimeters. So expect small dark triangle between the implant crown and natural teeth. And special attention must pay to the papilla. Within 4 months after the extraction, we lose about 40% of bone. The situation like this, I used to use twist drills to full sequence and place 4.1 millimeter implants, which would result in more bone adhesions and more buccal on the buccal aspect of the implant. With small diameter implants, about 3 millimeter in this case, placing toward the palate and proper use of rotary osteotomes, in this case denser burrs, I don't have to remove much bone. If I have a bit of exposure, I shave a bit of bone to place directly on the exposed implant surface and do a contour augmentation with xenograft and membrane. In this case, I use Strawman Flex, which is very pretty good also. and you use PTF, use suture to attach the membrane to the palatal plate, palatal soft tissue. This is 4 months post-op. In this case, a mucogingival procedure was done. I was trying to increase the papilla height by harvesting a wide base connective tissue from the palate. This is a modification of the vascularized interpositional periosteoconnective tissue graft, like VIP, also known as rotational palatal pedicule graft. Crazy, huh? Why? So in this case here, a split thickness were done on the surface, and the connective tissue graft was cut from here and flapped up like a wing. The whole thing is rotate under the buccal flap. This part here is stuck under the papilla. This is the connective tissue graft from the palate tucked under the papilla. And then we fold it under and then put the suture. Temporary crown was made 3 weeks after. Final impression. At insertion. With time, we may see a small increase in papilla heights, but don't expect too much. This is another case here. Root fracture caused extensive bone loss around the lateral incisor of this 75 years old patient. There was also a large apical lesion on the central incisor, which might compromise the lateral implant placement. So I removed the lateral incisor and did an endodontic treatment on the central. But in this case, I need to see complete healing of the apical pathology before proceeding with the implant on the lateral incisor. So we have to wait like 4 months. This is an example of why we have to use type 3, because we have to need longer period to make sure the adjacent pathology is gone. Soft tissue healed over the socket. And we have a huge defect involving both buccal and palatal wall. So in this case, a full thickness palatal flap was raised and bone block was harvested from the palate. Don't do this very often because the nose is right there. So only when you see in CBCT that you have enough thickness of the palate away from cavities, sinus cavity or the nose in order to do this. And so an implant was placed with minimum stability. And this little block graft was secured with a pin. And in this case, I put some contour of my GBR. And this is the final result, more than 7 years. The patient is really old now. Of course, you often find that different implant placement protocols can be done at the same time. In this case, for example, On the upper left side, stage approach was done 8 months before the implant insertion, involving lateral sinus lift and horizontal and vertical bone augmentation. This is a type 4 placement protocol. On this upper right side, we have a combination of internal sinus floor elevation, socket shield technique here, and immediate type 1 is a socket shield technique. This is an immediate implant placement, wrist expansion, and horizontal GBR with 50% bios and 50% of autogenous bone, BioGuide, bone tack. And you can see these slides because it's so interesting. We put on this side here, we put a vertical augmentation using tenting screw, a titanium reinforced PTFE membrane, and root submersion technique. And then we, after we graft this area here, vertical graft, we remove the root and put an implant, immediate implant, using a socket periosteal inhibition technique. The result is quite acceptable. This is done because the mental nerve is very high up here, about like a few millimeters from the crest right here. So we don't want to involve this tooth here. So we just do a augmentation in the back here. In this one, we do a more conservative approach by the periosteal inhibition technique. Works really well. So this is a case here. So, in conclusion, alveolar heart and soft tissues alteration is a biological response to tooth loss, which often prevents the placement of dental implants in an optimal position, which is essential for aesthetic and predictable outcome. In a full heel ridge, a type 4 placement, which occurs after 4 months or more after tooth extraction, most of the remodeling has happened. Extensive ridge augmentation procedure with both bone and soft tissue are often necessary, which requires longer treatment time and morbidity. Since there has been much tissue loss, restoring these cases in the original appearance is less predictable. When a late placement is anticipated, socket preservation procedures should be planned to minimize changes in ridge dimension. Immediate and early placements allow placing an implant in an extraction socket, which has a high osteogenic potential. The immediate placement protocol adopts the socket preservation principles to minimize both hard and soft tissue alteration. It also allows faster treatment time. Conventional immediate placement as with socket preservation help improve significantly, but does not prevent all the ridge shrinkage. A soft tissue augmentation procedure is often required to restore the original tissue volume. New immediate protocols such as socket shield technique and periosteal inhibition focusing on the preservation of the buccal bone has shown good results. Although an implant can be placed at an infected socket after thorough debridement, active infection or extensive apical or periodontal abscesses or granuloma associated with the affected tooth need time to heal after the tooth is removed. Early placement protocol allows resolution of infection and better soft tissue condition for primary flap closure, while avoiding further bone loss. The preference of one type over the other depends on the availability of bone for implant placement. The exact 3D implant position, implant diameter and length, volume of hard and soft tissue are important parameters in achieving optimal aesthetic outcome and stable long-term results. I thank you very much, and we should now, if you have any question.
Yeah, I have a question here. In when there is a lot of bone resorption, and you're placing a bone graft, and then you have a membrane on top of it. You know, when patient, after the procedure, when the patient goes home and we're waiting for the healing to happen, usually during function, like there might be some mechanical forces on the area that could possibly destabilize the bone graft or affect the stability of it. How do you deal with that? How do we maintain the stability of the bone graft in place? What's the best way to achieve that, in your opinion?
Any kind of immediate implant, regular implant, or bone or augmentation, bone graft, soft tissue graft, you have to educate the patient to be careful, especially immediate implants. You tell them don't function on it for 1 month, 1 month at least. And same as soft tissue, we have to be very careful. That's education, but then you cannot control that. So GPR has changed quite a lot since the beginning 20 years ago. Before we have a bone graft, and when we just put a membrane over that, soft membrane, a resorbable membrane, or double membrane technique, one area and one the other area, but that is for very minor GBR. To do a proper GBR with extensive like tissue, bone loss, like you mentioned, you need very solid membrane technique. That means you have, if you do, you know, just normally we can say, but you can just, there's no law, but you can say to do a horizontal augmentation, you can use with resorbable membrane. And so choose a membrane that's very strong, stable, that can last longer. And you have to do certain suturing technique or bone tacks to secure the membrane, like in an Israeli urban technique of sausage technique, very tight, that will help with stabilize the bone graft.
So like because titanium mesh, maybe? Titanium mesh?
That is, I'm talking about, yeah. I'm talking about the soft tissue. If you do soft tissue just for the horizontal augmentation, then you have to really tight. You see, many of my cases that prevent, the membrane is very tight. It's like packed. Yeah, then you will minimize the chance of mobilizing the graft. Now, another one that's very strong is like for horizontal or vertical, small vertical, you can use the non-resorbable membrane. I'm thinking of PTFE membrane, and that will cover over that also very tightly. Usually you need to do bone tack. Some and then very tight. If you have a loose like bone, you might have soft tissue overgrowth or easy to cause infection sometimes. But the problem with the PTF is higher chance of exposure of membrane. So sometimes we have to be forced to remove the membrane a bit earlier. So these are things that you have to consider. However, vertical augmentation, you need a membrane that is very strong, usually can be a titanium mesh, or you can use a titanium reinforced PTFE membrane. But it's very important for this to be done with proper tissue mobility. That means you have to be able to have you have attachment sutures, that is how do you call it? Soft tissue have to be released so that you don't have tension-free sutures. Does that answer your question?
Yes, thank you.
Ivan asked, how much horizontal bone do you lose approximately in soft tissue type? In soft tissue biotype with periosteal inhibition technique, what is your concept in short of using tissue level implant? How much horizontal bone loss approximately? Ivan, I have used a pilot study for this on for the socket preservation, and this very minimum is unnoticeable loss of bone, but this is only about like 7 cases and 3 cases of immediate implant. So I'm doing a bigger 40 patient case with a control to see if it's actually it is the case for that. So, but for that small study, I lose very little, say 0.1 millimeters. So I'm positive on that technique. Any questions? Anybody want to put up the case? You can unmute yourself. If it's no other question, then we can call it a night. And I thank you so much for joining my webinar. And we hope that some people talk about concept in short of using tissue level implants. Tissue level implant I use a lot. I was trained with Straumann before, and I used it for around like 10 years. And then the bone level comes. And so I did some immediate, and I switched to bone level. But for the posterior area, I have sometime good success, sometime not good success. And I don't know why. And in my case, I use bone level implants from Straumann, and I realized that the lab used a third-party parts, and it caused bone loss. So I look back at my tissue level for like many years, and they all like very stable. So I recently tried to put up a lecture on that to rationale why the tissue level implant is so successful. It follows, it's an own implant, but it follows many of the new principles that we understood now, we are learning now, is basically one abutment one time, microgap, platform switch, many new concept that that would apply back to tissue level implant might explain why these implants are so stable with time. So maybe if you have some chance, you can join us with the tissue level implant lecture. I don't know when. It could be end of this year, could be early next year. But I promise I will do that, because the last time I wanted to do that in October, in June or July, but something happened to my personal life that that did not allow me to do that one. But I always want to introduce that, because I am fascinated with the tissue level implant. I do it all the time now, if I can, in the posterior area, because I know that I will have a very long-term success with the treatment. Yeah. Okay. So I think that should be it for today. Thank you so much for everybody for joining, and thank you.